So hello everyone and welcome to the Mindscience TV and with my special guest Bob Rosenbaum. You'll notice a slightly different process with my image coming up, but that's because we had a slight problem with recording, so I've re-recorded my vocals. Bob is a really interesting person because he's a clinical psychologist. He's a neuropsychologist, so he understands a great deal about brain and mind, and that's why he's in here in Mindscience TV. Is an expert with single session and brief therapy in the Ericksonian tradition, but he's also a senior teacher of Diane, the wild goose in Qigong. He's written a wonderful book, Zen, the Heart of Psychotherapy. He's also been a Fulbright professor at the National Institute of Mental Health and Neuroscience at Bangalore in India. Also the California Institute of Integral Studies, and is director of psychology and the doctoral program at one of the major institutions in America. And he's just someone who captures this extraordinary interplay between the neuroscience, the technology, the academic, and the very humanistic aspects of spirituality, and in his case Buddhism, and the areas of finding a humanistic experience is really the point of what a therapist is looking for. Bob takes people on treks into Nepal, into the Himalayas or the Himalayas, depending on your particular pronunciation. And this, I think, gives us a unique opportunity to speak to someone who has, well, actually, it's not one foot in either camp. He has both feet in both camps because they're an integral part of Bob's experience. So, well, you'll notice there's a slightly different technical thing because my sound didn't work on the recording, so we're re-recording my questions. But the hero of the show is Bob. So, what I first want to do is ask Bob, what is this integration between, and how do we deal with this neuroscience and with this Buddhist type of approach? And can you speak to that?
Well, it might be worth mentioning how I got into the field of neuroscience. It was not my original intention, but many years ago, back in the mid-1970s, when I did an internship, it was at the Boston Veterans Administration Hospital, and I was doing a psychiatry internship there, and I had not realized that this was probably the best place in the world to be exposed to neuroscience at that time, because they had Edith Kaplan, Norman Geschwin, Benson, Marilyn Alpert. I mean, just an enormous array of people, and it was, I met these folks, they did some seminars, and I just went, wow, this is really good stuff. And it's a very exciting time to be there. So I was lucky enough to see a number of clients where we would have neurobehavioral rounds, and they would be staffed by all of these folks and by psychotherapists and psychoanalysts and whatnot. And they would talk about people from this very broad view that you're describing, and there'd be debates. So I remember one case in particular where there was a person in fairly early stages of dementia who was also depressed. And the therapist, a very senior psychiatrist, treating the person, said, oh, this person is aware that they're losing their faculties and they're feeling very sad about it, and they need to be able to ventilate and talk about it. And he filmed an interview where he said, so, how are you doing lately? How's your memory? Oh, doc, it's terrible. Oh, and the patient was very, very sad. And he said, yes, this patient's very, very depressed. And then my main teacher was Edith Kaplan. She came in and interviewed the patient, and she said her point of view was, well, this person actually does not have the cognitive wherewithal to really be depressed in the way that we understand depression. And what you're thinking is depression is actually what she called frontal pull. to go along with whatever cue the person is presenting. There's a phenomenon of frontal where, as people write, if I'm writing and I ask somebody else to write, they will write right over my fist, in order to complete a line. So she sat down with the patient. She said, "So you've been feeling very upset lately and very down." And the patient started crying. And then Edith went, "But you really enjoy playing basketball, don't you?" And the patient went, "Oh yes, I just love shooting baskets whenever I get a chance." And it was a very convincing demonstration that this was a person whose filters towards environment had eroded, and was very dependent on external stimuli more than on interoreceptive processing. Edith, I'll talk about her just a little bit because some of your viewers may know. She died pretty recently, I think just last year, and she was a force of nature. Talk about somebody with heart. Her main thing was to say, you sit down with a client and you have to see things, see the world through their eyes. And how can you do this? And so she, I had been brought up psychoanalytically and, this very restrained thing. And she would sit down and offer a cup of coffee and, pull the person's arm out and say, "Oh, look at the knitting on that sweater. It's just wonderful." And people would be very engaged, which was very important for how you would interpret neuropsychological test results. So rather than saying you must give this standard administration and be very precise, she would do anything she could to get the best possible response from a person. And then she said something which I've actually tried to convey to all of my students. The main thing I learned is, she said, whatever a test is labeled and calls itself, that's not what it's measuring. Now, this is somewhat heretical, but it's true. So her whole thing was, you have to watch how a person completes a test. So if a person fails a test because they're slow, that's very different than because they fail a test because they're distracted, which is very different. You can fail a test because you're too hasty. You can fail a test because your brain can't put the pieces together. So the score on a test was never so important for her as watching and observing and empathizing with the client or the patient to see, okay, so what has happened in this person's brain or emotions or environment or whatnot to give us kinds of results. I remember, there's one standard test, the Wechsler scales that are often used neuropsychologically, and there's one piece in them where you put these little boxes together to make certain shapes. And it's a fairly difficult test, especially as you get older. And I had one client who just did terribly on all the tests and was clearly having, severe dementia, except this one test, this block design test, where he just zoomed through, did a great job. We said, how could he do that? How could he do that? This is a difficult test, and he shouldn't be able to do that. Well, turned out he'd been a bricklayer all of his life, and a person who would put tiles in walkways. So he'd spent 50 years putting things together and fitting the pieces together, and this was an overlearned skill for him. So it made perfect sense, interpreted in terms of the context of his whole life. If you just looked at the scores, you would say something very strange here. So her influence was profound on me. She came from, there's a whole school of neuroscience which is not given a whole great deal of attention these days, which was the organismic school. And she was firmly in that camp. And it's certainly useful to balance some of the freedom of interpretation, which she occasionally indulged in, with the rigor of norms and standardized evaluations and whatnot. But we've gotten to a point now where people are becoming a little too literal in their interpretations of phenomena, which phenomena are complex. That's all there is to it.
Yes, it's a lot to do with what we notice, isn't it? I mean, noticing is a really important thing. You know, noticing it's not only from the client, but also
Yes,
yeah, you know, to the aspect of the client to you as well. And noticing is something that maybe not everybody's really all that good at.
it does put me in mind of the old the Sherlock Holmes and Watson joke. You're familiar with that, where it's nighttime and they're out in the woods, and Holmes says to Watson, "Watson, look up and tell me what you observe and what you deduce." And, well, Holmes, I see glowing objects, and those could be moons, or no, they could also be planets, or also stars. And this leads me to deduce that there are other stars and other galaxies in the universe, and perhaps other planets than our own, and perhaps we are not alone in the universe. What do you think of my deduction, Holmes? And Holmes turns to Watson and says, "Watson, someone has stolen our tent."
Yes, poor old Watson. But you know, this just triggers me off into thinking. You know, when we're looking into the stars, looking into the mysteries, looking into the amazing universe, but your tent's been stolen. This thing of imaging that we now do, we now look in. You know, we now look into people's skulls with fMRIs and MRIs and all these sorts of things. So this has given us new scope of understanding what's really going on. It was technically going on, but even still, you know, they're not that precise and not that issues. I know you have some opinions about this, and you know,
Oh, certainly. Well, first of all, I want to emphasize these are wonderful tools. And when I first, this certainly dates me, but when I first started learning neuropsychology, the CAT scan was just beginning to be adopted. Very, very few places had them. And until we had the CAT scan, if a surgeon needed to do a brain operation, they would ask a neuropsychologist to give a battery of tests, paper and pencil tests, to a person. And based on those paper and pencil tests, we were asked to say, it's this area of the brain which is affected. And they would do their surgeries and look for where the tumor was on the basis of our paper and pencil tests. I am very, very happy that we can now use CAT scans and MRIs to locate where the tumors are and let the surgeons go in that way. Much better. Much better. However, I think many people aren't aware of the technical limitations. People within the neurosciences are aware of these. But for example, any kind of subtle changes in the brain really cannot be picked up by CAT scans, certainly by structural MRIs and by CAT scans at this point. So that if I am 62 years old, if you were to give me an MRI or a CAT scan, you would see little spots on the scans. Now, those spots indicate, you know, there's been some cell loss in those areas. Cell loss, as one gets older, is normal. But you could take two CAT scans or two MRIs, and they'd have the same number of spots, and then the spots would be the same size. They'd be just little spots, and for one person, they'd be incapacitated by them. And for another person, they'd be functioning absolutely just fine. And we don't really know what these little spots mean. My personal hypothesis is if you happen to have the bad luck to have a little spot in just the wrong place where all the relays are crossing, well, not so good. But at this point, we really cannot diagnose subtle impairments with MRI or with CAT scans. And actually, our neuropsychological tests are still considerably more sensitive than the MRI or the CAT scan at this point in time. That will probably improve. A lot of what's seen in the literature of, we found the spot in the brain which does such and such are PET scans and functional MRIs. Now, those tell us something a little different, but they're not useful diagnostically yet. They're interesting for research, but there's so much individual variation between people that if you take a single person's scan, unless it's something obvious like a tumor or a stroke, which these will show, if it's not obvious, it really leaves you going, well, yeah, there's something there, but we don't know what it means necessarily. So there are also technical limitations to all of these things. I don't know if you want to go into them, but the main thing is, they only tell us so much.
Yeah, this is the dilemma of scientific work with individuals, but actually you research it in massive groups, and then you sort of individualize it, but then you generalize it. It can get very, very tricky.
Yeah.
But it just brings to mind of a fascinating slide I saw was of a Chinese group and of a European group, and what they did was they gave them a mathematical sum, these were mathematics, and they did an fMRI to see which areas of the brain would light up. And it was really extraordinary to watch the fact that the Chinese minds lit up with entirely different parts of the brain, some similar, but entirely different process. So the fMRI showed that the Chinese cultural approach, this approach to producing maths was very different from the Western version, even though they end up getting the same answer. This is really, to me, was very surprising.
Yes, that's exactly correct, and it goes back to what I was saying about how you perform an activity is more informative than what your final score or the outcome of the activity is, because you and I and most people have different ways of performing the same activity. So that first of all, when we say, oh, this is the area of the brain which seems to be involved in such and such, usually those studies are based on fairly small numbers of individuals, and they basically average out the individuals, so that if you had 16 Anglos and 6 Chinese subjects and 14 Hispanics, all of the little differences between them would wash out, and they'd say, okay, well, this is where most of it happened, but it doesn't tell us how far off a particular an individual might be who could bring the task just perfectly, but perhaps with a different part of their brain. If you are multiplying, and I formed probably a bad habit when I was in grade school, multiplying, where whenever I would carry a number to a column, I keep that number on my fingers. Well, I can tell you that since I use some ideal motor programming to keep that in mind, my brain, the scan of my brain will show something different than somebody who's keeping that in place, because I'm using motor functioning and other people will be using part of working memory. And so our brain scans would look different on fMRI, but we have to sort of you know, the brain scan studies, they're a little like, I don't think you have maple syrup in Australia, but the way you make maple syrup is you just boil it and reduce it and reduce it and reduce it till you get this very wonderful sludge, which is all that remains, but you've thrown out a lot. And what we're throwing out in the fMRIs and PET scan studies is all the wonderful individual variation.
Yeah, so I mean, even with all this wonderful technology to help us, there's still quite a lot of interpretation and I guess an artistic sort of capacity of being a neuropsychologist, and I'm experiencing some of this in the work I'm doing at Sydney University. It's not so much we're guessing, but we actually don't really know for sure. So here's the little question for you. Do we follow our intuitions? Do we trust the technology? Do we integrate? I mean, you do both. You have an understanding of both, and put you on the spot a bit. But how do you address the sort of having both tools? Is it useful? I just find the way you practice so interesting.
One of the reasons I got involved in psychology originally was I do feel it's very important for psychotherapists to realize that we are embodied minds. And I really did not want to miss a medical problem masquerading as a psychiatric one. And there certainly are cases where it's important not to do psychotherapy for a tumor which is going to kill you if you don't operate on it. I mean, it can be as simple as that. And so sometimes having the neuropsychological background is just very helpful to understand, okay, this is a person who has had this kind of head injury, or perhaps they have ADD, or this, that, or the other, and it's part of their makeup. And so the conversation that you have with that person needs to take that into account. Just as a very simple example, I actually have an interest in adult attention deficit disorder, because a substantial number of people who had ADD as kids have it as adults. Well, if you stop and think about psychotherapy as it's usually practiced, sitting quietly in a chair for 45 minutes, 50 minutes, this could be torture to somebody with ADD. Maybe that's not the best way of having a conversation. Maybe you should take a walk with them. Maybe you should have a 20-minute conversation with them, just as an example. If somebody is becoming demented, knowing how to handle the emotional processing is really rather tricky. It depends a lot on the kind of dementia, the stage of the dementia, how much to appeal to the intellect, how much to ask other people to just help them out and say, they can't do this. They just can't do this. You're getting mad at them is not helping. It's certainly true if you work with people who have traumatic brain injury, where they can, one of the things about brain function is you can have injuries in your brain and you look fine. And this can be very, very difficult for family members. And in this way, it's similar to psychiatric issues. So, what can a person do and what can't a person do, and what are the reasonable expectations, and what do we live with, and so forth and so on. So on the one hand, there's a very practical nuts and bolts kind of thing. On the other hand, well, let me give you an example, a rather specific example. I would sometimes see people who had seizure disorders. Now, seizure disorders are very interesting because they're classic neuropsychological, both neurological and psychological phenomenon. Sometimes we're called upon to determine whether a person is having pseudo-seizures. Turns out the research shows that virtually everyone who has pseudo-seizures, or a large proportion of them, also have real seizures, and a great number of people who have real seizures also have pseudo-seizures, so it gets a little fuzzy. But there's certainly an interaction between psychology and neurology here, and one of the things we know is to the extent that you're anxious, you lower the seizure threshold and make it more likely that you're going to have seizures. So one way of treating seizures is to treat the anxiety along with the medical treatment of it. And I remember seeing one couple where the person had a seizure disorder, and he started having seizures like 7 and 8 times a day with some pretty serious symptoms whenever he had his seizures. They were complex partial seizures, not grand mal seizures, but very serious symptoms. So his wife would get very, very concerned about him, naturally, and she'd hover. Well, the more she hovered, the more he got nervous. The more he got nervous, the more she had seizures, and the more she had seizures, he had seizures, and the more she hovered. So the treatment actually was fairly simple. It was, you know, it doesn't work to say to a concerned wife, relax. Just doesn't work. But what we did was we agreed that a few times a week he would pretend to have a seizure, and her job was to guess whether the seizure was a real seizure or a pretend seizure. Well, as soon as she started doing that, she changed from being very, very worried to, well, I wonder what's happening now. As soon as she started going, I wonder which it is, he started calming down. His seizures went from 7 or 8 a day to 1 every few weeks within the course of a couple of weeks. You know, it's very dramatic. So this kind of interaction between psychology and neurology, very, very interesting to me, and it's throughout the organism. In pain management, there's a kind of nice saying for those of us who worked in pain management. The strain in pain lies mainly in the brain. As it so happens, if you have chronic pain, you start developing different neurological structures than if you have acute pain. And one of the characteristics of chronic pain is the parts of the brain and basically the thalamic relays, which get hyperexcited and hypersensitized, don't have good localization portions to them. They don't have a good sense of where the pain is. So in chronic pain, it's quite likely that the pain will sort of float around the body. And then the chronic pain patients go in to the doctor, and the doctor says, well, you can't be having pain there. I mean, your injury was over there. But they are having real pain in the brain, yet, even though it's basically brain-related pain, I used to do something in our chronic pain groups where you can induce pain by wrapping a rubber band very, very tightly around your finger, and you cut off circulation, and pretty soon it turns purple and it's throbbing. And I would hold it up, and all the chronic pain patients in the group I would be working with were going, oh, take it off, take it off, take it off. And their faces would scrunch up in their elbow. And I said, well, this is pretty interesting, isn't it? That I'm having the pain, and you're having the distress. And there's a difference between pain and distress. And if one can work with people of distress, feeling of pain, the perception of pain changes. It doesn't go away, but the modulation of it changes. So these are some very concrete examples, I think, of how one would work neuropsychologically. But let me Well, maybe you can pause there and see what questions you have.
Yeah, this thing of pain, and Susie, my wife's a body worker, and so we do a lot of looking into the nature of the body as well as the nature of the brain, yeah, as you know, as it certainly is that that pain is a sensorial experience. The issues come up from the body and they come into the brain. But that doesn't mean that what comes into the brain is the thing that we feel as pain. I mean, I know one way to describe it is that there's a sensation of pain, but the thing we feel is very often the opinion we have about it, and sometimes our opinion about pain is not very good because we don't like it. But the true thing of pain is to stimulate us to respond. And in that way, we adapt. We utilize pain as a way of adapting. But the adapting brain is not. It's not always positive. It's not always sensible. Sometimes,
That's right.
Sometimes it goes off and it maladapts. I'm not sure how much the fMRIs tell us about this, but this is something that always is curious to me. Blending all this stuff to try and understand, what's going.
Absolutely. Yeah. It occurs to me. Let me say one other thing about using neuroscience in the psychotherapeutic situation, because there's a whole other aspect of neuroscience which doesn't get as much press, but which I think is actually more applicable for the psychotherapist, and that is cognitive neuroscience. So, for example, we know now, the research is very clear, that memory is not a matter of something happens and you have this little deposit in the brain, which becomes an engram, which then you subsequently retrieve, like taking a videotape off the shelf and sticking it in and playing it. That's just not the way memory works. Memory is sometimes been likened to, you have the skeleton of a script to improvise on, and your actor gives you your cue, and then you have to replay the same scene, but you're creating it each time. And there's all kinds of research which shows memory is incredibly fallible, just mind-bogglingly fallible, to the extent that you can, by the way you question people, you will change their memories, and they will then remember things differently for the next 40 years. And you can have people remember things that never happened. There's classic studies on this, and eyewitness identification. So what does this mean when you're working with a client? The idea of recovering the memory, the past, is just wrong. I mean, there's no such thing. Or you see a couple in therapy and they argue, it's such a classic thing. Oh, we took that photo in Italy. No, we took that photo in Germany. No, you're wrong. No, I'm right. And they go back and forth. They're both probably wrong. I actually have this argument with my partner. Say, I don't trust my memory. Why should I trust yours? I mean, both probably are making this up as we're going along, but it gives you a very different view of the past. Just as an example of a piece of neuroscience which isn't about neuroanatomy, but which we have good data on. The fact that work recently on behavioral economics is fascinating, to find out that there are all these priming effects. Staying with memory for a moment on psychotherapy, the idea of the 50-minute hour, which is very bizarre. I mean, it's very good for billing purposes, but it's not at all useful necessarily for psychotherapy. So if you have an important experience in a psychotherapy session, and we then say, well, this is at 20 minutes, so we better continue for another 30 minutes, that experience will have less effect than if you stop therapy at the point of the experience. Because we know that there are recency effects in memory, and that when you fill things in, it dilutes what comes afterwards. So this is basic neuroscience. but it can affect our practice.
Yeah, I mean, this area now of memory reconsolidation, which is starting to get a lot of traction and starting to make a lot more sense. Been talking to Bruce Ecker about this, who's done some stuff, but I'm also, this is what I've been studying in the certainly at the Brain and Mind Institute. And that's really interesting, how when we bring the brain back to a labile state, that we can alter the nature of the way we relate our memories to our emotions. So it's it's the most amazing thing for PTSD, but that's another discussion. But what we do and what's useful that's been dealt with a lot, mindfulness, meditation, these sorts of processes, which also have strong impacts on our memory and the way we relate to things. And of course, I guess you're a good person to ask about mindfulness and meditation, because that's sort of the stuff you do.
Well, I could go on for some time here, so stop me. Let me start by saying that I know John Kabat-Zinn. My sister worked with him for 20 years. My sister's a major mindfulness teacher. I think they've done a wonderful job of introducing a very important field for processing and for working with illness, with emotional difficulties. But I also think it's gotten a little skewed. Mindfulness, as it first was introduced into Buddhism, was a technique to deconstruct the self, to realize that we're these conglomerations of transient experiences which come and go. And it was not really meant as a technique for calming yourself down and being able to achieve better results in whatever activity you want to achieve, which is how mindfulness is sometimes being used these days. Yeah, so, and it can even lead to people kind of blaming people that you're not mindful enough, which might not, oh yeah, which is my sister, who is a wonderful mindfulness teacher, and because she had non-Hodgkin's lymphoma and we died of it, kind of concentrated on using mindfulness for coping with cancer. But she's very realistic about it. And in terms of being in the present, actually when I was in Australia last time, I was talking to a friend there who had taken the mindfulness training, and I said, oh, perhaps you know my sister. And she said, oh, your sister? Oh, yes, I remember. I was taking the mindfulness training, and we had a series of classes where they were very strict about saying to us, you must be in the present, and that means giving up hope, because hope is future-oriented, and you must give up hope. And then your sister came in, and she said, well, when I was in the ICU and nearly dying of cancer, hope was pretty important. It was very helpful. She's also had people, when she was in the throes of her illness, come up to her and say, well, this cancer is really an opportunity for a good practice, which is something we sometimes say in Buddhism. And at one point she said to me, if I hear one more person tell me that this cancer is an opportunity because I'm going to slug them, let them practice with it. But in terms of being in the present, well, the Diamond Sutra, very old sutra, says the past is gone. We know that, right? The future's not here yet, right? We can all agree with that. Then it adds a third statement. The present cannot be grasped. If the past is gone and the future's not here yet and the present cannot be grasped, what time do you exist in? I spent a year in meditation trying to be in the moment. Just like, okay, now, whoops, it's gone. No, now, no, don't think about it. we have very, very naive notions of time. Very, very naive. There's a neuropsychology of time. There's different clocks in the brain, but time is not necessarily what's measured by clocks. I mean, that's one aspect of time. A. Dogen says the self is time. You are the time of your life. Now, that's a rather different way of looking at it. And if you are the time of your life, what is that? It's not so obvious, is it? And this is an antidote to the kind of grasping that is endemic to our culture. And if Buddhism is about anything, it's about non-grasping. So, you know, for me, the central aspect of Buddhism is the primacy of immediate experience, which is why, coming back to neurology a little bit, a lot of people were very impressed with the book My Stroke of Genius, where the woman describes how she had a stroke and certain portions of her brain, that's right, weren't working, so she had other experiences. And it's interesting, but I can tell you, I was hiking in the Himalayas about 6-7 years ago, and I had a stroke. And what was most important that I took from that experience was I was alone for a while. My companion had to leave me to go get help. So I was up in the high mountains of the Himalayas, and I was sort of going, I'm going to recycle my legs. My companion's going, I could die here now. And I looked around and I kind of protested the mountains. I said, I might die here now. And the mountains kind of looked back and went, so? Join the club. Which was a very wonderful experience. So much more important than what was my brain doing and what was shutting off and what was shutting on. And that was interesting as I explored it later on. The experience of really getting the idea that we're mortal, profound. More profound than any front, back, left, right of lobes in the brain. And the kind of existential meaning of this stares you in the face. So, how do you respond? It's actually kind of back to what we were talking about with Edith Kaplan and what we call the process approach. How do you respond? Not what, not where, but how. What's the quality of your life? In mindfulness meditation, in psychology and brain research, it's very good to be looking at happiness. But happiness is not a feeling. Happiness is a way of living. If it's a feeling, it's going to come and go. If it's a way of living, it can be the fount of your life.
Yeah, so true. I mean, I sometimes describe happiness in a sort of simple way as just being able to that the person that you believe in is inside of you is able to express itself on the outside. It's sort of living yourself in whatever state you're in at the time. And this sort of brings us to this sense of harmony, this sense of flow. We look at chaos theory. I know we do that. We move from rigidity to chaos. But if we find that pace between rigidity and chaos, where we stimulate ourselves when we get too rigid and pull ourselves in when we get too chaotic, we actually can get to this sense of harmony. Yeah, this is what all things in the body, the cells do it, everything does it, and the whole idea of the body is to find this state of harmony, a state of being within, within successful parameters of yourself.
Yes, exactly. It's a harmonization, really. And one of the things which is quite wonderful about the brain is it's constantly harmonizing. We look at these little locations in the brain, and they're interesting, but there are just tens of thousands of electrical impulses going through all the time, and it's like a symphony. And we don't have the capacity right now to look at how the patterns are shifting and morphing, and what a fascinating thing it is. But it's so much richer than the little pieces that we're starting to get a little bit of insight into. That I would really hope that people can appreciate the richness of it.
Yes, I think it's understandable, the way we put it into bits, but because we're trying to understand the whole, sort of, break things down, disengage them to re-engage them. But it's the beauty of not only of the connection of ourselves, but the connection of us with other people. I mean, this interpersonal neurobiology stuff with Dan Siegel that we do. I mean, this idea that it is the engagement with others that enables so much of ourselves, of these elements, to integrate and come together and be this wonderful thing we call a person.
And whatever program you watch, it will be different if you share it. Share the experience with someone else. Which is again why the brain research, I mean, our brains are made to be interpersonal organs. They really are. And having had a number of CAT scans and MRIs in my life, let me tell you, sitting in this little chamber with this thing around your head, and you're told, now don't breathe too deep because we'll get, movement artifacts. It's a pretty artificial environment. I don't know how much it tells us about, what we're doing when we're walking along and being bombarded by stimuli.
Yeah, absolutely. And bombarded we are. But I mean, perhaps we could say that we've been bombarded by stimuli over the last 45 minutes or so together. And but I'm afraid we have to call it to quits a bit. I'm sorry, wish that we could talk forever, but hopefully we'll catch up again in America sometime soon. But I don't know. I wonder if we can conclude with sort of some pearls of wisdom, something that you might be able to add to leave people to take away with them. If you could have a go at that.
Well, pearls of wisdom, I'm not so sure about. There is a famous Zen. Famous Zen koan, which perhaps I'll mention in a moment. Before we leave, I think I will plug my forthcoming book. It won't be out till next spring. It's called Walking the Way, 81 Zen Encounters with the Tao Te Ching. And I actually take each of the 81 verses of the Tao Te Ching and write just a little something about what this might mean for our life, and then put a personal anecdote in. And there's a good deal of neuropsychology and psychology in there as well. But the first verse of the Tao Te Ching basically says, the way that can be named is not the eternal way, but names engender everything. So names, I think the first line of my book says, your name is a summons, not a self. You're not what your name is. You have many names. We need names. We need to call on things and we need to reference things, but we shouldn't mistake names and labels for the realities. And I think it's important to maintain a sense of humility and wonder. There is a Zen koan about pearls. There was a Zen teacher who said, whenever anyone asked him a question, he'd say, all the world, all the universe is one bright pearl. And finally one student said to him, you keep saying to everyone, all the universe is one bright pearl. I don't understand. And the teacher said to him, all the universe is one bright pearl. What need is there to understand it? We do have a need to understand. It's fine to understand, but let's enjoy the pearls. They're all around us.
Well, that's just beautiful, Bob. I can't think of a better spot for us to wind up this interview. I'm sorry we have to do so. And I look forward to spending more time with you in the future. But for now, thank you so much for being on Mindscience TV. And everybody out there, I hope you've enjoyed this interview as much as I have. I'm sure you have. And we will see you next time at the next exciting adventure of Mindscience TV. Thanks, Bob. Thanks, everyone.